Okay. The title of my presentation is Behavioral and Pain Pharmacogenomic Testing for Ehlers-Danlos Syndrome Patients. So objectives for today is to review the pharmacogenomics program at Children's Hospital Los Angeles, describe the pathophysiology and symptoms of Ehlers-Danlos syndrome, and apply current pharmacogenomic guidelines in pain and anxiety and depression management for EDS patients. So a brief introduction to our hospital. It's a 413-bed freestanding acute care pediatric hospital with over 700,000 patient visits in a year. We do have a busy emergency room, about 90,000 emergency visits. And I think the unique thing about our patient population, with it being in California, we do have a high percentage of Hispanic and Latino families. So I'm housed under the personalized care team. So this program was really to optimize care delivery and outcomes for children through the application of genomics and other health-related innovation. So there's a lot of things going on under this umbrella, but you'll see pharmacogenomics is one piece of that. So in regards to my clinic, I'm housed in the GTAC clinic, which stands for Genetic Test Assistance and Counseling Clinic. So there's two current pathways that we do. We do a panel testing if it's just for pharmacogenomic testing that includes 16 genes, and it's the typical 2-visit model that we have. And then we also do whole genome sequencing for patients that are coming to our clinic for diagnostic that looks for genetic diagnosis as well. So the whole genome sequencing we do does include pharmacogenomic genes as well, so I do counsel on them. So moving into the condition that we'll be talking about today, which is Ehlers-Danlos syndrome. So this is a group of heritable connective tissue disorders supporting the skin, bones, blood vessels, and many other organ tissue. And this can lead to a range of symptoms from mildly loose joints to life-threatening complications. The combined prevalence of this is 1 in 5,000, but the most common type that we see is hypermobile, which is also about 1 in 5,000 cases, while the other cases are more rare with a couple in each of those subtypes. So there's been a current, continued research on what genes are involved in causing this group of connective tissue disorders, and there's 20 genes that have been identified thus far. The ones starting with COL are the ones involved in the genes providing instructions for making pieces of several different types of collagen, versus the other ones are involved in providing instructions for making proteins that process, fold, or interact with the collagen. So overall, it's affecting the production and processing of collagen, leading to these range of symptoms that we see in these patients. But we do see up to 50% of them being a de novo mutation. There's different types of Ehlers-Danlos syndrome. It originally started with 11 forms that were named in Roman numerals, but then a group of scientists switched it over to the Villefranche classification, which was really genetic-based, and that included 6 different subtypes that you see here. So you see majority of them were autosomal dominant versus a couple were autosomal recessive. Hypermobility is the most common one, and then vascular will be the most dangerous one. And then in 2017, they reclassified it to include a couple more subtypes, especially the more rare ones that were identified. So now we have a total of 13. So you can see a lot more autosomal recessive types were identified during that time. So in regard to pathophysiology, just like I mentioned earlier, this is heritable variants in connective tissue genes. So some types of connective tissues that are involved are collagen, fibrillin, and matrix proteins. And just like the previous slide said, there are a mix of autosomal dominant and recessive types. And then most common pathophysiological changes that we see are ligament laxity, fragility, and impaired healing. And this is what really causes the main symptoms that we see in these patients, which are pain, reduced movement, and decreased cardiovascular fitness. So there's a range of symptoms, and it's really unique between each individual and presentation. So, but there are some hallmarks, which are generalized joint hypermobility, which is the most common one, but also the hyperelasticity in the skin and atrophic scarring. So I really like this image where it shows kind of affecting almost every organ in their bodies, and it's really affecting their day-to-day life. And the most common and most kind of the symptoms that really affect them the most are the chronic pain and the fragility that has been most commonly reported. And then I like this image because it shows that even if you have two people with the same subtype of EDS, they are presenting very differently depending on the symptoms and the capacity of those symptoms. So you'll see on the left-hand side, this one experienced a lot more headaches and fatigue versus the patient next to them is experiencing more joint instability and pain. So we will be focusing on the pain and anxiety that presents itself for these patients. So in regard to management, there is no cure. So it's a lot of it is very symptom management only. And this condition, just like you saw on the previous slide, involves a lot of different organs. So a multidisciplinary team to really combat each of those organs is very necessary to help them. So you can see the different disciplines that might be involved in their care on the right side. Prevention is really the most crucial thing, especially with the hypermobility, with the joints being more flexible and stuff. You really want to help them build their strength and modify their lifestyle to prevent any big injuries that can cause more pain or more other symptoms. So there is limited evidence. There's no real specific guidelines for EDS and their management, and a lot of it is taken from other similar conditions, especially fibromyalgia. So a lot of that is extrapolated. So focusing on kind of the pain management, I really like this image from the paper from Zoe and her team. So when it comes to pain management in EDS patient, it really presents itself as nociceptive pain initially, but with time and as they grow up, it really builds into a neuropathic pain and central sensitization pain. And as we know, those are a little harder to treat. So you can see that really depending on where they are in the condition and the age, the pain can be different. So these underneath here are some examples of pain therapies that have been kind of mentioned in these people. There are no kind of big trials that have presented that some of these drug classes are better than others in this patient population. So that's a missing piece in evidence that we do need to better help manage their pain. In regard to opioid, they do kind of encourage to limit that as short term as possible due to the potential long-term development of central sensitization, and with NSAIDs to kind of limit that as well due to the concerns of gastrointestinal issues, which already present for them with the disease itself. We don't want to exacerbate that even more. There has been some success with tramadol use in these patients, and then steroids have been helpful in acute exacerbation of joint pain. In regard to anxiety and depression, so these patients often experience secondary anxiety and depression due to that chronic pain that they're experiencing, and also kind of the lack of comprehension from institutions really understanding what they're going through and their condition to be able to help. So they kind of feel very lonely in this journey of getting treatments and help. So that can lead to a lot of more psychosocial concerns. So a lot of psychiatrists are unfamiliar with the medical care of genetic disorders, and more clinical evidence is needed to really better define the potential subtype of anxiety that they are feeling And then there has been a case report of using risperidone for treatment-resistant anxiety that was successful for that one patient. So again, these are some common medications that will be used in the anxiety depression that has been mentioned in the literature so far for EDS, but they do conclude that none of them have really shown to be kind of better than the other. It's really, again, extrapolated from other guidelines and conditions. So moving on to how we can apply our pharmacogenomic guidelines to help with their pain and behavioral concerns. So starting up with pain, these are some of the examples of pain that we do have guidelines for. So opioids, we have the codeine and tramadol, NSAIDs, and our tricyclic antidepressants. So just a quick review of what our CPIC recommendations are for the opioids. So in regard to codeine and tramadol, they are prodrugs that have to be activated by CYP2D6 to their respective active metabolites. And in regards to recommendation, ultra rapid and poor metabolizer, it is to avoid those medications to prevent respiratory depression or lack of efficacy. And an intermediate metabolizer, you could consider alternative if you don't see any improvement. This guideline did look into other pharmacodynamics targets, but concluded that there were no recommendations and there were still weak evidence for hydrocodone, oxycodone, and methadone. So with CYP2D6, we always have to think about phenoconversion. So for example, here you have your tramadol being metabolized by CYP2D6 to O-desmethyl tramadol. So if you have a patient who is CYP2D6 normal metabolizer, but then adding bupropion as a strong CYP2D6 inhibitor, this will then further inhibit CYP2D6 and you'll be phenoconverted to CYP2D6 poor metabolizer. So just a reminder about the key common CYP2D6 inhibitors. So you have your strong ones, bupropion, fluoxetine, paroxetine, and your moderate one, duloxetine. So I just want to highlight this again just because the complexity of these EDS patients, they might be on so many different medications, and the frequency of them probably having another inhibitor in place is pretty high for them. So just something to really consider when you're getting results back for these patients. Moving on to NSAIDs, so these are affected by CYP2C9. So most of the recommendations are around intermediate metabolizers with activity score of 1 and your poor metabolizers across ibuprofen, celecoxib, meloxicam, and piroxicam. So there were alternative therapies that are not affected by CYP2C9 that you can recommend are ketorolac, naproxen, and Zoladex. Moving on to tricyclic antidepressants, so you have your tertiary amines, amitriptyline, clomipramine, doxepine, imipramine, and trimipramine. So those are metabolized by CYP2C19 and 2D6. And then you have your secondary amines, nortriptyline and desipramine, being metabolized by CYP2D6 to inactive metabolites. So for tertiary amines, you have to consider both their CYP2D6 and CYP2C19 results, and combining them, you'll get the recommendations here by CPIC. So you can see majority of them have some recommendations besides the normal and intermediate metabolites. And then moving on to your secondary amines, these are only affected by CYP2D6, so you have recommendation for your ultra-rapid, intermediate, and poor metabolizers. So moving on to the next therapeutic group, which is anxiety and depression medication. So you have your serotonin reuptake inhibitors, tricyclic antidepressants, and antipsychotics. So in regard to serotonin reuptake inhibitors, starting off with the ones affected by CYP2D6, which is paroxetine, fluvoxamine, venlafaxine, and vortioxetine. So some recommendations for ultra-rapid for paroxetine and vortioxetine, but no strong evidence for fluvoxamine and venlafaxine. And then only intermediate for paroxetine, while poor metabolizer across the 4 medications. And then moving on to citalopram and escitalopram, which is affected by CYP2C19. So they metabolize them to inactive metabolites. So we do have recommendation or guidelines for ultra-rapid, rapid, intermediate, and poor metabolizers. And then sertraline, also a 2-gene. So you have CYP2C19 and CYP2B6. So the ones in blue are the ones in yellow are the ones that require some adjustments in their standard doses. And then I did also wanted to just mention risperidone, since it was mentioned in that one case report. Currently, we only have Dutch pharmacogenetics working group guidelines right now. So they recommended for CYP2D6 ultra-rapid metabolizers to choose an alternative or titrate to maximum dose of the active metabolite. Nothing for intermediate, and then lastly for poor metabolizers to use 67% of the normal dose or continue decreasing to 50 if they are experiencing central nervous system side effects. And that concludes my didactic portion. Any questions?